Sir, from Kerala. Yeah. All the best for the 2, 4, 6, 7 presenters. Let me call upon. The first presenter, Dr. Siddharth Seth, is ready. Siddharth Seth.
Dr. Siddharth Seth.
Yeah, please come.
Please come. Your name is first.
You have two presentations. You have two presentations?
You have two presentations.
Yeah.
So are you going to do them back to back? The order is
Yeah, I
like
think.
that. It's okay with us.
But we'll consider them as separate papers. So
Okay,
like,
okay.
yeah.
No problem.
Yeah.
And you can carry on with
Yeah.
your second presentation.
Yeah.
And the third presenter is Dr. Jebin Brand. Is he here?
You
Jebin?
should be ready. The next presenter,
Yeah.
please be ready.
Good morning, everyone. I'm Dr. Siddharth Shet, and topic for my free paper is influence on angle alpha on modulation transfer function and higher order aberrations in eyes implanted with trifocal IOL. We do not have any financial disclosure to make. Angle alpha is the angle between optical axis and visual axis. Angle alpha is helpful in predicting visual outcomes in eyes implanted with multifocal IOL. Higher the angle alpha, it results in reduced visual quality and unwanted symptoms like glare and halos. However, there is limited literature available about influence of angle alpha on post-operative visual outcomes, particularly with trifocal IOLs. Acrysof IQ Panoptics is a trifocal IOL which provides excellent uncorrected far, intermediate and near visual acuity. Panoptics is first US FDA approved trifocal lens. So we decided to study the influence of angle alpha on MTF and higher order aberrations in eyes with Panoptics trifocal IOL implantation. It was a prospective study done on 56 eyes who were implanted with trifocal Panoptics IOL. The study duration was between September 2019 to February 2021, and age group of the patients was between 40 to 70 years. We included the patient with best corrected postoperative visual acuity greater than 0.2 logmar units. Subjects with IOP more than 22 millimeters of mercury, any other ocular disease, prior refractive surgery or intraoperative complications were excluded. Angle alpha is the distance between the center of visual axis and optical axis. So it can be measured in terms of angle as well as the distance between the image, the 2 points. Eye trace abrometer was used to measure the angle alpha at 1 month post-operatively. For statistical purpose, the eyes were divided into 2 groups. Group 1 included the eyes with angle alpha less than or equal to 0.45 millimeters, and group 2 included eyes with angle alpha more than 0.45 millimeters. We chose 0.45 millimeters as cutoff based on previous literature, where the mean angle alpha value was documented as 0.44 millimeter for preoperative cataract patients. Internal higher order aberrations were measured for fixed 4 millimeter pupil size using eye trace abrometer. Modulation transfer function, which describes the ratio of image contrast to object contrast, was obtained at spatial frequencies of 5, 10, 15, 20, 25 and 30 cycles per degree for again fixed pupil size of 4 millimeters using eye trace abrometer. 2 sample t-test was carried out to compare the MTF and HOA between the 2 groups. The mean angle alpha in group 1 was 0.33 millimeters, whereas in group 2 it was 0.56 millimeters. Internal modulation transfer function were better as seen in this graph with lower angle alpha, that is in group 1 as compared to group 2. But this difference was not statistically significant. The internal higher order aberrations were similar in both the groups. So we did not find any effect of angle alpha magnitude on higher order aberrations and modulation transfer function in patients implanted with Panoptics trifocal lens. This could be possibly attributed to the inner ring diameter of the Panoptics IOL, which is 1.164 millimeter, which is more as compared to other multifocal and trifocal lenses, thus tolerating more magnitude of angle alpha. Higher order aberrations are small but more complex refractive errors that cannot be corrected by glasses. and are responsible for degradation of retinal image quality. In the present study, we found similar higher order aberrations in both the groups, suggesting no significant effect of angle alpha on higher order aberrations. In the present study, mean MTF was calculated at different spatial frequency, where MTF was found to be better in eyes with smaller angle alpha, but this difference was not statistically significant. To best of our knowledge, there is only one study which has evaluated the effect of angle alpha on post-operative visual outcomes in same IOL. However, they have not studied the effect on higher order aberration and modulation transfer function. So more studies are required to explore this area. Higher order aberration and MTF, both metrics are pupil dependent. So we used a fixed pupil size to calculate both the metrics, unlike previous studies where no information about the pupil size was mentioned. So to conclude, we did not find any effect of angle alpha magnitude on higher order aberration and MTF in eyes implanted with Panoptix trifocal IOL. This can be attributed to the IOL optic design, which can tolerate the larger angle alphas. However, a larger sample size and long-term study is required in not only in this IOL but other multifocal IOLs also to confirm the findings. Thank you.
How many patients did you have?
56 eyes, ma'am.
56 eyes.
Eyes.
Divided into 2 groups.
Yeah.
Okay. And suppose one were not to use the Panoptix IOL. You don't have a study on that with any other lens.
There is currently a study going on to compare between the Panoptix and the other trifocal or multifocal IOLs to find out the difference between the two, whether the other IOL is performing similar to Panoptix or no.
What is the maximum angle alpha you found in your
So we
group
found
2?
the maximum up to 6 in one of the
0.60.
patients. But yeah, so yeah.
Okay.
Any questions from the audience?
And did you find any difference between the toric IOL, toric Panoptix and non-toric Panoptix?
So
Any
in this
difference
study, we have only included the plain Panoptix trifocal, not the trifocal,
this doesn't
not the
include-
toric ones.
Not the toric.
Yeah, yeah.
And subjectively, did the two groups have any difference?
Subjectively, patients did not
There's
complain.
hardly any
Yeah,
difference.
yeah.
Did any of your patients complain about glare following?
That is the next paper he is going to.
Acha.
So yeah, that's
Okay,
the next.
okay, chalo, we'll
the
read-
similar same patient group. Yeah. Yeah. Can you open next PPT? It's I think no next not that. ईशान है तेरा। ये नहीं है। मैं इधर से करूँ ठीक ओके So, good morning once again. I'm Dr. Siddharth Sheth, and topic for my free paper presentation is effect of glare on contrast sensitivity in eyes with trifocal IOL with high angle alpha. So this is a subset of the previous study only, so same patient eyes. For trifocal, bifocal and other modern design IOLs with diffractive rings, centration of the optic is more critical. Angle alpha is helpful in predicting the centration and visual outcomes in eyes with multifocal IOLs. Higher angle alpha results in reduced visual quality, glare, and other unwanted symptoms. However, there is limited literature available about the effect of glare on contrast sensitivity in eyes with trifocal IOL with higher angle alpha. Acris of IQ Panoptix is a trifocal lens which provides excellent uncorrected far, intermediate, and near visual acuity. Panoptix is the first US FDA approved trifocal lens. Thus, we studied the effect of glare on contrast sensitivity in eyes with Panoptix trifocal IOL with higher angle alpha. It was a prospective study done on 56 eyes who were implanted with trifocal lens. So the study duration was again same between September 2019 to February 2021, and patient age group was between 40 to 70 years. Post-operative best corrected visual acuity better than 0.2 logmar units were included in the study. Patient with subjects with IOP more than 22 millimeters of mercury ocular disease, prior refractive surgery, or any intraoperative complications were excluded from the study. So angle alpha is the distance between the center of visual axis and optical axis as seen in this diagram. Eye trace aberrometer was used to measure the angle alpha at 1 month post-operatively. For statistical purpose, we divided the eyes into two groups based on angle alpha magnitude. Group 1 had eyes with angle alpha which was lesser or equal to 0.45 millimeters, and group 2 had angle alpha more than 0.45 millimeters. We chose 0.45 millimeter as cutoff based on previous literature, where the mean angle alpha value of cataract patients was determined to be 0.44 millimeters. So effect of glare on contrast sensitivity was measured at post-operative 1 month using CSV 1000 HGT vector vision chart. Contrast assessment was done at 4 different spatial frequencies, 3, 6, 12 and 18, with and without glare. This instrument has different spatial frequencies, where from left to right the contrast sensitivity keeps reducing, and at the same time it has a light source which is automatically calibrated by the machine. So we can use the light source, or without the light source we can calculate the contrast sensitivity. Total 56 eyes implanted with panoptic IOL who met the inclusion criteria were included. Mean age was 54.45 years. Distance best corrected visual acuity mean was 0.12 logmar units. Mean angle alpha in group 1 was 0.33 millimeters, whereas in group 2 it was 0.56 millimeters. In both the groups, as we can see in this table, the contrast sensitivity was reduced in the presence of glare. Without the glare it was better, in the presence of glare it was less in both the groups. But this was statistically not significant except at the spatial frequency of 3, where it was statistically significant. Also, the contrast sensitivity was found to be reduced in group 2. If you compare group 1 to group 2, the contrast sensitivity was lesser in patients with higher angle alpha. But again, this difference was not statistically significant. So ideally, we want the diffractive rings of trifocal IOL to be concentric with the pupil and the center of the optic lined up with the visual axis. This will give the best visual performance with the IOL and the best satisfaction of the patient. This means smaller angle alpha, that is closely placed optical center and visual center, will give the best possible quality of vision. In our study, even though we did not find any statistically significant effect of angle alpha magnitude on contrast sensitivity with or without glare, this could be again attributed to the inner ring diameter of the panoptic IOL, which is larger as compared to other trifocal or multifocal IOLs, thus tolerating more magnitude of angle alpha. In the present study, the mean angle alpha value was 0.56 millimeter, which is almost half of the IOL inner ring diameter, which can incorporate even up to 0.6, 0.7 millimeters of angle alpha. Contrast sensitivity is more complete performance related measure of functional quality of vision after cataract surgery. In the present study, we used Vistec contrast sensitivity chart, which is more reliable and repeatable. Vistec measures contrast at different spatial frequencies, unlike other standard contrast sensitivity chart like Paley-Robson or Bailey-Lovie chart. So to conclude, no significant effect of glare on contrast sensitivity was noted in eyes with higher angle alpha in our study of patients implanted with panoptic trifocal IOL. More studies with larger sample sizes are required for evaluating the effect of magnitude of angle alpha on contrast sensitivity in patients implanted with modern day trifocal or EDOF lenses.
In my opinion, if these two papers could have been combined into one, you just needed to add glare to the subject of the first paper, because the group is the same, the patients are the same, the time is also the same. It is the same group. You
Exactly,
also
the
admit
patient,
that.
yeah, but only the instrumentation was different.
That could have been included in the first paper. Only thing is, you got the benefit of presenting two papers instead of one, to be honest.
I was not
I'm giving my
expecting
frank
both the
opinion.
papers to get accepted.
But anyway, it's all right. But did you all take subjective opinion of the patient into consideration? Because very often the instrument may not measure glare you know.
Yeah.
But
Yeah.
subjectively, the patients do complain. So
Did
was
they have any problem in
yeah,
their
did you
day-to-day
all
life?
ask, was that part of your study or no?
Yeah. So, ma'am, this is actually a sub-part of a larger study which we are doing where other aspects of the trifocal lenses.
That means another third paper is
No,
coming.
not in the currently in this thing, but that will be coming. So, in total, it will be coming in future. Yeah.
Sorry
So
for
I-
that,
yeah.
but just to keep it a little light-hearted.
I think we'll.
I appreciate the feedback. Yeah.
No, fine. No, but I wanted to know that because, subjective complaint of glare is very common in patients, especially those who drive
So
at
that-
night.
Ma'am, just to add this, the paper which we are this ongoing study where we are evaluating it with the other IOLs. So definitely we have found subjective also, but which was again lesser in lenses like panoptics as compared to other lenses.
There is no financial interest
No,
huh,
ma'am,
in
no.
No, you have not. You have to mention that first.
You should have mentioned that. In both your papers, I was about to say, since you are mentioning the name of the IOL, you must write that there is no financial
Ma'am,
interest.
I have
You've men-
mentioned.
Have
Very
you?
good.
Yeah,
Very
yeah, I
nice.
have
Very
mentioned on the second slide.
Okay,
Yeah, very
perfect.
good.
That's the way to do it. Okay, fine.
Thank you.
Any other questions?
There was a mesopic pupil and mattress in such studies.
Yeah, so exactly in such studies, the important part is the pupil size. When you change the pupil size, all the values will change. So we have kept a fixed pupil size of 4 millimeters. That is a option available in iTrace thing where you can select a fixed pupil size and only on that pupil size you will get the values.
So who was the surgeon here?
It was a mixed
Multiple
surgeons
surgeons.
for yeah.
Multiple
It's
surgeons.
not a single
No,
surgeon.
not a single.
And was the IUL centered with the Purkinje images of the
Yeah,
microscope?
intraoperatively that was
That-
seen.
I
and
think that is very important.
yeah,
we
that-
should
that
we
was-
should have
yeah.
added into your
Yeah.
this thing presentation that because that makes a lot of a difference. Otherwise, decentration. Primarily, if the lens is decentered, if it is not at the
Exactly.
Purkinje image, and all were done under topical anesthesia or under the block
So
anesthesia.
out of 56 eyes, 3 were under local anesthesia and remaining 53 were under
Total, how many cases were there?
56 eyes.
No. These are after the exclusion criteria.
Yeah,
after
yeah.
incorporating
so
the
during
exclusion.
that study period, the number of surgeries which were done with the same lens was around 89. But after the excluding all the other
I
criteria,
think that has to be
Yeah.
that total 89 cases were there,
Yeah.
but we have included 56.
So, yeah,
That
according
is
to
the
our
right way.
criteria, 56. will
Yeah.
be.
Okay.
Okay. We'll go to the next one.
Yeah.
Yeah.
Thank you so much.
Thank you.
Next person? The next author is Dr. Jabin Bran. Is he there? Dr. Jabin Bran? If he's not there, we'll go to the next person because we won't waste time. Dr. Nikhil Balakrishnan? Yes, please come. We won't write no yet because he may just
Yeah.
come.
Yeah. By your.
There is time still. Nikhil, you also have 2 papers.
Yes.
So you can do both simultaneously, one after the other. Just till his talk is getting loaded, I have a small point to make which I am going to take up with the chairman scientific committee of AIOS also. Discouraging use of own laptops. You must bring your presentation on a pen drive, put it in, load it, and
Yeah.
no. I don't mean that, but in general, that should be the criteria because this changing of laptops also takes up time.
Yeah. True. Yeah.
And actually, why should you worry about your paper getting stolen or anything? Ask them to delete it afterwards. at the worst. And even if it does get stolen, so what? In the preview room.
There is some technical glitch, ma'am.
Really? Say that on the mic, Feroz.
But today, I
But,
think he was
but
doing
he was using his own laptop. I think
the
Siddharth.
previous speaker.
Siddharth, you were using your own laptop?
No, okay, that's
Okay.
my lab.
Okay.
Yeah, yeah.
What's the glitch?
You should have one laptop only. And
It
in
is one.
that one laptop,
Yes, you should have all the presentations
presentations.
loaded for one second.
Good morning, one and all. My topic for today is hydrojet peeling versus posterior capsular polish for removal of lens epithelial cells. So we all know that there is a progressive fall in visual acuity as the PCO increases. This is very well documented. So what happens is that the residual lens fibers which are left behind after cortical aspiration, when they proliferate, it leads to posterior capsular opacification. So as you see in this figure, after the lens cortical aspiration, there are these small particles which are called as residual lens fibers, which are left behind on the posterior capsules. So our study was to find out if there was a safe and effective method for the removal of these residual lens fibers. The materials and methods, it's a prospective, non-randomized comparative study. My sample size was 960 eyes, that's 480 eyes in the hydrojet peeling group, 480 in the posterior capsular polish. All patients who are above 55 years of age were undergoing phacoemulsification with IOL implantation done by a single surgeon. Exclusion criteria were traumatic cataracts, complicated cataracts, zonular weakness, and patients who were lost to follow-up in the 1-year period. Now, this was done by a single surgeon, a clear corneal incision using viscoelastic, 5.5 millimeter excess, hydrodissection, phaco using the Centurion Vision System. After INA, half the patients had hydrojet peeling done, half had the posterior capsular polish, and an implantation with an IQ monofocal IOL implantation. As already said, I have no financial interest. So this is how a hydrojet peeling was performed with a syringe and a normal cannula itself. Fluid jet was used parallel to the residual lens fibers to clear them out. Coming to posterior capsular polish, under very low settings of aspiration rate of around about 8 and the vacuum of just around about 14, very carefully the residual lens fibers were peeled out from the posterior capsule. So we did an intraoperative image capturing using the Zeiss Lumera eye microscope, a Sony Alpha 4K mirrorless camera, and Alcon video overlay system and a video recording system from the Sony. Intraoperative photos were taken prior to IOL insertion. On slit lamp, photos were taken on day 1 and 1 month, and finally at the 1-year period. There was quantification of residual lens fibers and PCO. This is grade 1, where there is absolutely no RLF left. Grade 2 is where there is RLF left outside the CCC margin, but it's trace. In grade 3, it's mild. In grade 4, it's inside the capsular excess margin, which is moderate, and in severe, it's inside the capsular excess margin too. What were the things that we assessed? The time taken in both the procedures, the vision assessment, that is the CDVA done, and finally the visual quality assessment, that is the objective scatter index, the Sterl's ratio, and the modulation transfer function. What are the results of our study? Procedurally, hydrojet peeling took on an average 34.2 plus minus 8.8 seconds, whereas posterior capsular polishing took much longer at 76.3 seconds. So there was a significant difference between the two. In the CDVA, on POD1, both had similar visions on both POD1, 1 month, but there was a significant difference between hydrojet polishing group, whereas the posterior capsular polishing group at the 1-year period. Now in the objective scatter index, again, there was a significant difference on day 1 itself between the two groups, and no significant at 1 month, but significant difference again between the two at the 1-year group. Similar findings were seen in the Sterl's ratio and also in the modulation transfer function, where significant findings were found on day 1 and on 1-year periods. Coming to the residual lens fibers, intraoperatively when they were photographed, we saw that in the hydrojet peeling group, it was basically grade 2. That means mild residual, that is trace residual lens fibers seen in the periphery mostly. Whereas in grade 3, that's the posterior capsular polishing. In that group, there were residual lens fibers even in the within the capsular excess margin. Finally, coming to the posterior capsular opacification, which was checked at the 1-year period, we found that as compared to the hydrojet peeling in posterior capsular polishing, there was significant amount of PCO seen at the 1 year period as compared to hydrojet peeling. The patients who developed PCO at 1 year were 11 in hydrojet peeling, whereas 36 in in the posterior capsular polish. Coming to the safety profile, in hydrojet peeling, we did not have a single rent, whereas in posterior capsular polishing, 5 patients had a PCR, as visualized here. So, hydrojet peeling is a safer and more effective technique for residual lens fiber removal as compared to posterior capsular polishing. What is the limitations of the study? Both techniques were performed by a single experienced surgeon and using the Centurion machine for the polishing mode. If the same study had to be performed by a less experienced surgeon and on a different machine which did not have as good safety parameters as this, maybe the results would differ. And the study period was relatively short. We were taking posterior capsular opacification into point of view, so 1 year was a relatively short study period. What new does the study add? It's a novel technique for removal of residual lens fibers and hence reducing the incidence of PCO. It's a safer technique with minimal risks and complications. It has a very small learning curve. It requires no extra equipment and hence extremely useful in low resource settings. And hydrojet peeling is a quick technique and so can be used very effectively. Thank you.
Yes, this is an excellent technique. And I have demonstrated this technique in 2012 at ESCRS. How to kiss the posterior capsule. Just with regular IA setting, which we are doing irrigation and aspiration, we can even kiss the posterior capsule and can remove any single fiber from the posterior capsule. Yes. Okay. Excellent technique.
I think very useful study because it's a very simple technique.
Yeah, very simple.
You know, normal cannula, normal syringe, everybody has it. And even if you don't have irrigation aspiration system with you, any surgeon can do this. And I don't really think what you said that the limitation was single surgeon and the machine. Nowadays, most of the machines are good. Most of the phaco machines are high-end machines. I don't think that's a limitation, and your number of patients is very good. One thing is there that PCO may show up after 1 year.
Correct.
So that is the limitation of the study. But otherwise, I think it's a very good study.
It's an excellent technique to not only to polish the PC but also to lift up cortex and residual epinucleus sub-incisional.
Yes.
You can direct it there and you can use the hydrojet. The only point you should always remember whenever somebody is starting off is never direct the cannula to the space between the iris and the anterior capsule into the sulcus. Then you will have a posterior misdirection of fluid and it will come up. That is the only point you should always remember because I saw a slight iris flutter in the first case that you showed. Otherwise, it's an excellent technique and well presented.
Thank you, sir.
Yeah.
Any other question?
No, ma'am. It's a wonderful presentation.
I would like to add here is, whenever you wash, you should at least present your videos also.
So I'd present
Yeah.
the
So
videos of both the techniques.
Yeah, but something, how you are polishing, you can push the fluid very, very intensely, very fast. The only catch here is just keep slight pressure on the scleral lip. That is very important, very, very important.
In order to let the fluid come
Yes.
out and not have it accumulate in the eye.
We do each and every patient of ours with hydrojet polishing since many years.
I think we'll have to go to the
Yeah,
next.
next one, next let us start.
Yeah. So my next talk for today is a baseball bat sign that is predicting.
It's okay, let him continue now.
No, here it is not coming.
Sorry? Actually, it's not coming there.
Yeah.
Okay.
Abhi, it's called. Yeah. So it's
Yeah,
called
that's
the baseball's bat sign that's predicting the prevalence of intraoperative floppy iris syndrome in patients on tamsulosin. Now, what we all know is that benign prostatic hyperplasia is a very common disorder in elderly males, and treatment of the same is usually with an alpha blocker, namely tamsulosin, which relaxes the smooth muscle in these patients. But what happens as a side effect of the same is that the receptors which are present on the dilator pupillae are also acted upon, and hence you develop something which is known as IFIS, that is intraoperative floppy iris syndrome. Now, like Dr. David Chang had correctly, has already published this data long back, that you have insufficient pupillary dilation, you have undulated and billowing of the iris prolapsing into the wounds, and intraoperative pupillary constriction. So, what was known was that there is IFIS, but IFIS does not occur in all cases in patients on tamsulosin. So what our study was performed was to see that is there a method to predict that which patients would develop IFIS if they are on tamsulosin. So the materials and methods of the study, it's a case control study. Sample size was 76 eyes in the test group, that is in patients on tamsulosin for more than 3 months, and a control group where patients were not on tamsulosin. Inclusion criteria was age above 55 years, male patients, and exclusion criteria was patients using other drugs for BPH, glaucomatous patients, complicated cataracts, and any condition that could alter the iris morphology. We did a preoperative cataract assessment, and besides the normal routine cataract things, we also checked the undilated. We did an undilated anterior segment OCT and an infrared pupillometry too. Now, what did we do is that we assess the iris pattern and assess the pupillary diameter under both photopic and scotopic lighting. In iris measurements, so here we see this is the scleral spur, the pupillary margin. The central area, half the distance between the two, is the area where the dilator muscle receptors are, and 0.75 millimeters from the pupillary margin is where the sphincter muscle receptors are. So what we did is also we did a pupil measurement, that is in the photopic pupil, we did a photopic and a scotopic pupil measurement. Now, we noted the incidence of IFIS intraoperatively when these patients were operated. Now, what our results were, the age, it was in a test group, was average 62.4, control group 61.9, not significant. The iris measurements. Now, here we saw that in the test group, that is patients on tamsulosin, there was a significant decrease in the dilator muscle receptor group, dilator muscle receptor thickness as compared to the in the control group. There was a significant difference between that. There was no significant difference in the sphincter muscle region group, and therefore the DMRT versus the SMRT ratio was also significantly altered. So here we see, this is a photo of the same, as compared to the control group, we see that here we see that both the dilator and the sphincter muscle region is almost equal in size, whereas in the test group we can clearly note that in the dilator muscle receptor thickness is lesser than the sphincter muscle receptor thickness. This is multiple patients demonstrating the same photo anterior segment OCTs. Now, because of the striking resemblance of this iris of the iris of patients on tamsulosin to a baseball bat, we coined the term baseball bat sign. Then we did the pupil measurements. In that we saw that patients on tamsulosin had smaller pupils, photopic pupil sizes, smaller scotopic pupil sizes, and therefore a smaller ratio between the two. Now, how many patients actually developed IFIS? No patients in the control group developed IFIS at all. In the test group, that is patients on tamsulosin, 62 out of 76 patients developed the signs of IFIS, that is 81.5%. So we found out that the use of a baseball sign, that is thinning of the DMR thickness of the iris on the anterior segment OCT, is a very reliable tool to detect occurrence of IFIS in patients on tamsulosin. Our study uses anterior segment OCT for predicting the occurrence of iris. It is the first study to demonstrate thinning of iris DMR thickness in patients on tamsulosin, and hence we coined the term baseball sign for that. And it also demonstrated that inadequate pupillary dilation in patients on tamsulosin using infrared pupillometry. Now, how do we translate this to our clinics? We would be better if we know pre-hand that the patient is going to develop iris. We can be better prepared to tackle IFIS intraoperatively by creation of longer wounds, controlled hydrodissection, avoid overfilling the chamber with viscoelastic, decompressing the anterior chamber periodically, and using a low-flow phaco while operating. The futuristic approach to overcome the limitations of our study is to find a method how to correlate the iris measurements with the anterior segment OCT so that would represent the real iris thickness. And if we could do a human cadaveric study to corroborate the iris dilator muscle region smooth muscle tone deficiency in patients on tamsulosin. Thank you.
Excellent. Very good. And you devised a new sign, baseball bat sign. And I think what you said about usefulness of this study in clinical practice, that is very important. Because just finding out that there is a probability of getting floppy iris will not help. But if you can predict it, and you are better prepared. The surgeon is mentally prepared that this could happen, and then you will perform the surgery accordingly. So, good job.
One question, the paper was excellent actually. Do you have 85% incidence of IFIS in tamsulosin patients these days? Do you come across IFIS 85% in patients on tamsulosin these days? Do you get, because we modify everything, we use a dispersive OVD to cover the iris, we use low flow parameters, but still did you get IFIS? Is that so?
By using this study was done where we did not, this was done pre-operatively, we did not know that this was happening. Now once we use the sign in our clinics nowadays, we find the rates of IFIS are much low because as you rightly said, we're making longer tunnels, we're using lesser low flow parameters. So the risk of IFIS, that means the iris popping out from the wounds and all, becomes much lesser nowadays by taking precautions.
But if it is going to occur still, in spite of all the precautions that you take, because the iris is floppy, so it is going to occur. So how do you tackle that? That is also important. Just being theoretical doesn't work. It has to be practical also. So how did you all handle it when you got these cases?
So the main thing in this is that the reason that when the iris starts popping out, the first thing is to decompress the anterior chamber. That's very important to reduce the pressure inside. So by depositing the iris after decompressing the anterior chamber, pushing, if it's done when the lens is in the bag, you push the lens downwards. Do not try to overfill the chamber with viscoelastic because that's not going to help. It's going to increase the pressure. So you decompress the anterior chamber, bring out all the excessive fluid, the viscoelastic, and then carefully deposit the iris back from the wounds into the position and proceed with surgery.
But it's going to pop out again in any case.
No. Have you used any time expansion device?
Yes.
Pupil
So
expanders.
in patients where preoperatively the patients had very small pupils, which was less than 4 millimeters, we did use either things like iris hooks or a pupil expander to conduct the surgery.
Which one?
The B-hex pupil expander.
Yeah, that's good.
And in drop, if you have a similar situation, people coming in, and IFIS, do you use an intraoperative midway iris hook insertion?
So if it becomes difficult for during surgery that the iris is constantly popping out and the pupillary area where you get to operate is very minimal, then in that case intraoperatively sometimes iris hooks can be used so that you get better access to the lens.
Any higher molecular weight?
Yes, so you could use things like viscoat, which is a higher molecular, Elon viscoat is a higher molecular weight viscoelastic to cause pupillary dilation first. You could also use a stretch pupilloplasty where you could stretch the pupil using a Y hook so that the pupillary area is increased. But
No, I think it is contraindicated
That
in
is
IFIS, remember.
contraindicated with
You should not do it.
Only high viscosity
Not
viscoelastic
intraoperative,
and
that wouldn't work.
pupil expanders.
Okay, I
Only
think
pupil
we'll stop
expander or
this
high
discussion.
viscoelastic?
We'll go to the next paper. Thank you so much. Who's the next person? Sagar, can you announce? Dr.
Shubham Harsh.
Shubham Harsh. Is Dr. Jebin Brand in the hall by any chance? Because if he's not there in another 5-10 minutes, we won't consider him.
Okay.
I think we wait till the end of the session. What do we do?
Let us wait. You can start.
We are waiting.
Yeah.
We will wait till the end.
Good morning, everyone. My topic is efficacy and safety of. Good morning, everyone. My topic for presentation is efficacy and safety of intraoperative intracameral mediatrics in manual SICS. Cataract surgery is the most common performed ocular surgery. A large volume of surgeries are performed in CAMP, where MS-CIS is the most common performed procedure. And a good pupillary dilatation is a prerequisite for performing surgery, which can be achieved either by instilling topical mydriatic agent 1 hour before the cataract surgery or by giving intracameral injection of mydriatic solution on the table by the surgeon intraoperatively. But using an intracameral mydriatic solution is still a less performed procedure. So the aim of this purpose of the surgery is to assess the efficacy and safety of intracameral mydriatic solution in comparison to preoperative topical mydriatic agent in patients undergoing to have manual SICS. The study design is a prospective randomized controlled comparative study performed from July 2020 to June 2021 at Riorim Sarachi. Approval was taken from the Institutional Ethics Committee and protocol was followed according to the principles of Declaration of Helsinki, and written and informed consent was obtained from the patient. Inclusion criteria includes the patients having diagnosed with senile cataract, having best scattered visual acuity less than 618, and all the patients were above 50 years of age. Exclusion criteria included the complicated cataracts, that is, patients having uveitis, corneal opacities, pupillary deformities, subluxated or dislocated lenses, or hypermature cataract. Patients having uncontrolled diabetes mellitus, or having a history of use of topical prostaglandins, miotics, steroids, etc., or having any past history of the surgery in the same eye, and the other patients who were not willing to give the consent. So total 72 patients were included, of which 37 were males and 35 were females, which were scheduled for elective MSCIS. Well, they were divided into two groups, having 36 patients in each, and were divided by a computerized block randomization method. Group A includes the patients were given preoperative topical mediatrics, which was having the regimen of tropicamide 0.8% plus phenylephrine 5% drops at 15 minutes interval for 1 hour before the surgery. Group B patients include intracameral mediatic solutions patients, and the solution was have a concentration of 0.5% lignocaine and 0.001% epinephrine, which was given intraoperatively. The amount of solution used was 0.2 to 0.3 ml, and pupil dilation was measured using a software called ImageG while recording on the monitor. Pupil size were measured at different intervals, that is P1, P2, P3, and P4. Where P1 was when the patient lays down on the operation table. P2 measures the time in group A when 1 minute after entering the AC through the scleral tunnel, and in group B 30 seconds after installation of intracameral mediatic solution. P3 is just time just before the intraocular lens implantation, and P4 is just before the removal of lid speculum. On the first post-operative, the logMAR of the uncorrected and pinhole visual acuity were determined in both groups. Corneal edema grading was done, and AC inflammation was evaluated and graded. All the findings were noted on MS Excel sheet and analyzed using SPSS 21 package. Independent t-test was used to compare mean pupil sizes between the two groups. Chi-square test was used to compare first post-operative day corneal edema and AC inflammation in both groups, and the value of P less than 0.05 was considered as statistically significant. So the number of patients were total 72. There was no significant distribution in both the sex distribution in both the groups, and neither the age distribution affected the result outcome. So table 1 shows the details of the pupil size measured at the designated time, where at P1 junction the p-value is really significant in both the groups, while the other 3 times, that is P2, P3, and P4, doesn't have a significant p-value. Now, table 2 shows the first mean post-operative day logMAR visual acuity of both in both groups, which were both insignificant. So table 3 shows the corneal edema in the first post-operative day, which was also insignificant, and AC inflammation on the table 4 shows the AC inflammation on first post-operative day in both groups, which was also insignificant. So discussion: instilling the topical mediatrics requires additional manpower. Increase in preparation time of patient can potentially contaminate the ocular surface, and there is a non-compliance of staffs or patient, which result in inadequate dilatation. While in intracameral mediatric, they substantially reduce the load of regular checking the patients for the dilatation and drop installation. It also reduces the chance of ocular surface contamination, and no additional manpower is required. Pupillary dilatation achieved in Group B patients was adequate and similar to Group A, which does not cause difficulty in any intraoperative procedure, including IOL implantation. And difference in postoperative day 1 visual acuity, corneal edema severity score, and AC inflammation was insignificant in between both the groups. So conclusion: intracameral mediatic solution is effective in inducing adequate mydriasis in MSCI patients. The mydriasis induced is sustained enough for entire surgical procedure. It is effective and safe with respect to vision and AC inflammation on the first post-operative day, though the follow-up duration was small and inadequate to compare the result in post-operative 1 week and 1 month. So furthermore research needs to be done. These are the references. Thank you.
Thank you. It's a good study because it's an important aspect of manual SICS, having adequate pupillary dilatation, and you're very right that without it, it's difficult to operate. So good. I'll give you a small hint. You were well ahead of your time. Learn to go a little slow with your presentation. You were running like an express train. You didn't need to. You had 50 seconds left when you finished. So next time, keep that in mind. Otherwise, I think
How did you use every case? You used a different intracameral mediatic agent.
So once the solution was prepared, it can be used in all the cases performed in the same day of the OT.
And did you?
No, ma'am. Obviously, the needle was changed,
Okay.
but the solution was the same.
Did you use mediatic agent in the IV? This thing also.
Yes.
That BSS what you were using.
Yes, sir.
In that also you have added the mediatic.
So the solution was prepared using BSS.
No, that BSS, what we are giving, irrigating solution
Oh, no.
for that. It is only.
Yes, sir. It was just used for.
What is the pupil size? Any difference in pupil size? Because when we dilate by the drops and
So,
there is some differences there.
yes, sir. Before it was from table P1, it was really significant to us.
Insignificant.
So
That is it.
that
I'm
is the
just
significance
inquiring
difference
again.
because it was patients in group A were really dilated. That is around 7 mm.
Is there any comparative study? Has anyone else done?
Before same study was performed using in patients undergoing phaco surgery. This is the performed in MSCA surgery. Looked at it.
Thank you.
Isn't it better to know?
Very nice.
Yeah.
What preoperative medication you use for both the groups? Non-steroidal, anti-inflammatory
Fluoroprofen plus is also used.
for all the patients?
Yes. No, in group A only, sir. It was not used in
Okay.
group B.
I think the next person is.
Don't you think it is better to know that this particular pupil will not dilate preoperatively itself?
Yes,
You
sir.
got the point?
Could be-
Because we'll be mentally prepared that this particular pupil is small. You will plan, you will keep every device that is available and necessary.
Actually, sir, you should be prepared for that even in your pre-op assessment
But mentally
of
we'll
the
be
patient.
prepared.
When you dilate the patient when he comes to your clinic and you are examining him
True, that is-
pre-operatively, you find out
Yeah.
right there whether pupil dilates well or doesn't, and you can make a note of
Yeah,
that.
that is
But I disagree to some extent on your saying that pre-op dilatation is more cumbersome. It really doesn't require any extra manpower from our side. The relatives do it. The patient's relatives do it.
Sometimes,
Yeah, I mean that's
And
what.
we are introducing one more drug into the anterior chamber. There is
Yes.
always a risk, always an additional risk.
And additional cost also.
Yeah.
Which normally
Yeah,
we
we'll
will
go to the
normally we will keep
Intracameral-
it only for patients having intraoperative myasis.
Yes.
Then only we use
Actually,
it. Otherwise, we don't use it.
Yes, yes.
I think we should rush now. Thank you. I have to go for another session too.
Good morning, everyone. I am presenting on inverse relation between the vitamin C and the cataract development in the tertiary care of Jharkhand. My aim is to show the relationship between the vitamin C and the cataract development. The cataract is the leading cause of blindness and is responsible for 51% of the global blindness. The surgical intervention is the only available treatment for the cataract till date. The large population bundle, limited surgical facilities in the developing country, and long waiting list in the developed countries. Therefore, alternative to cataract surgery are required. Because of the proven association between the lens cataract and the oxidative damage, antioxidant supplement has been proved as a treatment strategy to slow the progression of the cataract. Consumption of the additional dietary vitamin C has increased in concentration of vitamin C in the lens. There is evidence that the incidence of cataract may be higher in the person who have low plasma concentration of the vitamin C. The study, this is a hospital-based prospective study. Sample size is 56, and both male or female are taken between the age group of 40 to 60. The duration of the study is March 2019 to August 2021. It is studied in the tertiary care center of the Jharkhand. Patients were randomized divided into two groups. In group A, the case was who was taken vitamin C, and group B is the control with a given placebo group. Informed written consent was taken. Participants were interviewed using the questionnaire asked by 24-hour recall. 15 ml blood sample was collected in the same day of interview into the two different tubes, and the sample were quickly transported in the insulated container to avoid the light association of the vitamin C degradation. All the vitamin C biochemical analysis was completed after the maximum of 3 hours from their extraction. A simple calorimetric method for the determination of the ascorbic acid in the blood was used. log2 system was used to classify the type and grade of the cataract. Statistical analysis was carried out using the SPSS software. In result, total patient are 56, cases are in case 27 and control 27, and 2 patients are left in the mid of the study. Other history was taken as the 41% from the cases and 48% from the control had active lifestyle. 44% from the cases and 48% from the control had the alcohol intake of more than 91 gram per week. The chronic alcoholic intake interferes with the absorption of the vitamin C, leading to the early formation of the cataract. Other history like smoking in group A, 37% have no history of smoking and 22% had past history of smoking. In group B, 33% have no history of smoking and 26% had a past history of smoking. In study, it shows that there is increased dietary intake of vitamin C, showed at inverse association with the cataract risk. Odd ratio is 0.39 with the intake of more than 185 milligram daily being associated with the greater benefit. Level of ascorbic acid more than 64 micromoles per liter shows that the strong protective effect from cataract with respect to the level equal or less than 64 micromoles per liter. In discussion, this is Maria Pastor et al. Shows that there is increased dietary intake of vitamin C has inverse association with the cataract risk of the result, which is match our study. In this study, there was no significant difference between the serum ascorbic level in the male and female, contrary to the study result conducted by S. Miratesi and Bestarsi, which has shown the plasma level of vitamin C were significantly higher in the female population. Similar study was done by Ravila R. Ravindran et al. In the Arabinda Hospital, Pondicherry, India, reported that there was an inverse association between the vitamin C and the cataract. Conclusion is that high intake of vitamin C more than 185 milligram per dl or serum ascorbic acid more than 64 millimoles per liter has an inverse relation with the development of cataract. Thank you.
Basically, you are advocating that people should start taking more vitamin C. But from when? From which age should they start? Because, this is something which you'll have to tell your patient.
Yes.
You start taking vitamin C from now. Some patients may develop cataract earlier. Some may develop it later. So how do you judge that? How will you advise your patient when to take it? This is what I found, the drawback of your study. Fine, agreed that vitamin C levels are important.
It decreases the load of the cataract because in our countries there is a lot of backlog.
All that is agreed, Dr. Lakra, but my point is, when will you advise your patient to start taking?
Yeah.
It's like calcium. We tell women to start taking after 35 nowadays.
Okay, it can be done in any age group.
Pardon?
The cataract can be in any age group. Mostly in the senile cataract was there, but this cataract is developed in any.
Agreed. So, I think maybe that can be your next bit of study.
Okay.
When to start.
Okay, madam.
Okay?
Thank you.
Sure. Thank you. Next person.
Good morning to all of you. I am presenting author with the topic Effect of Pupil Dilation on Biometric Measurements and Power Calculation, Formula with the IOL Master.
So you are a non-ratified member. Yeah. Okay. So we will not be giving marks to you. Okay. But you are.
I am having no financial interest in any of the product or techniques mentioned or discussed in the study. The success of cataract surgery depends on many factors, one of the most important being accurate calculation of IOL lens power. 3 main measurements are used for the IOL calculations are axial length, anterior chamber depth, and corneal power. Currently used optical methods include the IOL Master 500, Lens Star 900, IOL Master 700. For more than 15 years, IOL Master have been benchmark. Third generation IOL calculation formulas such as SRKT and Hofer-Q do not include anterior chamber depth and lens thickness. However, fourth generation formulas such as Hagees, Holaday include both ACD and the lens thickness variables. When the ciliary muscle is relaxed, the suspensory ligaments are taut, which cause the lens to be thinner, thus ACD becomes deeper. To evaluate the influence of the pupil dilation on biometric measurements and recommended IOL power calculation by third and fourth generation formulas using IOL master was done as the aim of the study. The study was prospective, observational, comparative study done between August 2022 July 21 at FRIMS, Ranchi, and the ethical approval was taken from the Institutional Ethics Committee. All age-related cataract was included, excluding those with prior eye surgeries, with an active ocular pathology such as uveitis or retinal degeneration, or with inability to fixate because of any eye disease and prior contact lens use. When both eyes met these criteria, only the right eye was included into the study because measurements will be more similar between the fellow eyes than individuals. For each participant, 2 biometric measurements were acquired using the IOL Master 500 prior to and after dilation. Every measurement was done in the same examination room and under the same scotopic light condition. Recommended IOL power for SM60 WF9 were calculated by the 3rd generation SRKT and 4th generation Haigis IOL calculation formulas. For a descriptive statistical analysis, we use Excel 2011. Result was shown on the mean plus minus standard deviation. Significance was set at p less than value 0.05, and data were compared using a paired sample t-test. A total of 52 eyes of 52 patients, where 30 were male and 22 were females, with a mean age of 66.53, having range 52 to 81 years, were included in the study. This is a table showing the ACD with a significant mean difference with of 0.12 plus minus 0.35, and the keratometric reading and the axial length having no significant difference. This is a table 2 showing the IOL power calculation using the SRKT formula having no significant difference, while the those calculated with the Haigis have the significant difference of 0.07 plus minus 0.54. The axial and the corneal power measurements did not differ significantly after dilation, having value 0.005 mm and 0.001 respectively, while the ACD had a significant increase of 0.12 plus minus 0.35 mm. Variation coefficient was higher for the ACD versus the axial length and the keratometric reading. The IOL power choice based on the SRKT formula was not affected significantly because of the dilation. The Haigis formula showed a significant change in the calculation post-dilation. A number of studies have reported the influence of the pupil dilation on the biometric measurements. Cheng et al., Heng et al., and the Sheng et al. Found that the AL was not significantly affected by the pupil dilation. Villalobos et al. Observed no change in the corneal curvature radius after dilation, but Seto et al. Demonstrated that the pupil dilation could influence corneal curvature radius. Cambipant et al. Showed that the ACD was significantly influenced by the pupil dilation. The significant axial length variation after dilation found in our study was consistent with the previous finding of the IOL master reproducibility and repeatability. Nevertheless, the significant increase in the ACD with a variation coefficient of 4.14 is interesting, and this is the only factor clearly affected by the dilation. It would be logical that the IOL power calculation formulas based on the ACD would be altered. This would be especially important for users of formulas that include ACD into their ELP algorithms such as the Haigis, Holaday 2, Olsen formulas. Finally, the conclusion is there is no clinically significant effect of pupil dilation on the IOL master measurements of axial length, corneal power, and intraocular lens power calculated using the SRK-T formula. However, a significant increase in the ACD and the IOL power calculated is found using Haigis formula. Thus, pupil dilation status at the time of the IOL master acquisition should be reported when submitting data for constant optimization. Thank you.
Good paper and good data, but the thing is, you have these two formulas are different. SRKT formula doesn't take into consideration the anterior chamber depth. So you should compare it with the two formulas which take into consideration the anterior chamber depth, like a Barrett formula and other formulas. Then only this comparison is relevant. And otherwise, this presentation is misleading that if you are doing it with SRKT formula, then it is no significant differences there. So we can use that also. But ultimately, what matters is the latest generation formula has come just because they take into consideration effective lens position. because all these things matter into the effective lens position, and then we have a accurate IL power calculation. But anyway, your efforts were good. Thank you.
Good morning, everyone. I'm here to talk on the accuracy of the new Kane formula in comparison with SRKT and Barrett Universal 2 in myopic eyes. At the onset, none of the authors have any financial interest in the subject matter of this study. So to begin with, refractive cataract surgery and the demands for it has necessitated the need for accurate IOL power calculations. Now, why are the IOL power calculations difficult in high myopes? So it's primarily because of the inaccuracy of the axial length measurements, higher chances of ELP prediction errors, and leading to hyperopic surprises. So how can we approach this? So there are literature search has shown two important studies. One is by Kane et al., wherein he showed a statistically significant lower mean absolute prediction error when he compared it to the other 6 formulae. And there's another paper wherein they compared Holiday 1, Hagees, and Barrett Universal 2, in which they found that Barrett Universal 2 performed the best in axial length, wherein it was more than 26 millimeters. So this brings us to the aim of our study, which was to assess the accuracy of the new Kane formula in comparison to the conventional SRKT and Barrett Universal 2 in eyes with axial myopia. So the Kane formula was developed in the year September 2017 based on a data of about 30,000 cases. It's freely available on iolformula.com, and it uses the theoretical optics, regression, as well as AI components. So we conducted a retrospective comparative study wherein we recruited those patients who had underwent an uneventful phacoemulsification with axial length of more than 26 millimeters. These patients had all underwent the optical biometry using the LensStar, and then we did the IOL power calculations using the Kane, Barrett Universal 2, and the SRKT. So we found that in a sample size of 333 eyes, the mean age was 54.74 years, and women were more predominant as compared to that of men. Now, coming to the Kane formula, it showed the lowest median absolute prediction error when we compared it to the SRKT and the Barrett Universal 2. The Kane formula also showed the lowest absolute prediction error across all axial length groups, meaning 26 to 30, 30 to 33, and 33 to 35. And when we compared the percentage of eyes with a prediction error of a given diopter, say 0.25, 0.5, 0.75, and 1, the Kane formula had the highest percentage of eyes in each group. Now, what makes Kane formula different? So while SRKT is a theoretical model with empirical regression, the Barrett is a theoretical model. It's a 4th generation formula. But of course, while the SRKT does not take into account the ACD, like Sir pointed out, the Barrett Universal 2 does take into account the ACD as well, apart from the axial length and the central corneal thickness. Now, coming to the Kane formula, it has a component of AI as well. And it uses all these variables for estimating the ELP, namely the biological gender, the axial length, keratometry, anterior chamber depth, lens thickness, and the central corneal thickness. In our cohort, the Kane formula had the lowest median absolute prediction error, standard deviation of error, and highest percentage of eyes across the dioptric range. We found about 11% reduction in the absolute errors in comparison to Barrett Universal 2 and a 16% reduction as compared to SRKT. To conclude, the new Kane formula demonstrated a significant improvement over SRKT and Barrett Universal 2 in myopic eyes across all axial length groups. We have known that SRKT is known to give good results in these cases with optimized A constants, and recent published studies have reported a good performance of the Barrett Universal 2 as well. To the best of our knowledge, this is our first study to assess the accuracy of the Kane formula in extreme myopic eyes. We are aware of the limitations, meaning the follow-up period was just 1 month post-operatively, and we compared only 3 formulae, though multiple formulae are available. Thank you.
Very good presentation. And have you considered Hill RBF also for this?
So now
because that also takes into consideration the AI And that is the only formula up till now possible.
In this paper, sir, we did not. But now we are comparing the same group of eyes with Hill RBF EVO2 and Olsen as well.
Olsen also. Okay, nice. Thank you.
Thank you, sir.
Any other question? Please, you can invite the next speaker.
Dr. Pavitra Patel? Yeah. He will, she will talk on plug the hole before you bell the boat. Modified hydrodissection to prevent iris prolapse. Pavitra Patel, please.
Does have any financial interest? Good morning, everyone. At the outset, none of the authors have any financial interest. I am Dr. Pavitra Patel Balkrishnan, and the topic for my today's presentation is plug the hole before you bail the boat, modified hydrodissection. The topic of my today's presentation is plug the hole before you bail the boat, modified hydrodissection to prevent iris prolapse. It's not going ahead. So from antiquity to today, managing iris prolapse has long been a challenge for cataract surgeons. Hydrodissection is an important step of phacoemulsification surgery. A complication that can occur during hydrodissection is iris prolapse, in which a part of the iris slips through the ocular incision. Risk is higher, as we know, in patients on tamsulosin or with shallow anterior chambers or with imperfect wound construction. So while going through the literature available, I came across this article wherein a phaco sleeve was inserted through the main incision, sealing the main wound. And then the hydrodissection was performed with the cannula inserted via side port. But the disadvantage of this technique was that occasionally the sleeve was displaced from its position, making the method ineffective and leading to iris prolapse. So the research question was that is there any novel modified technique of hydrodissection to prevent this iris prolapse? And so the aim of my study was to demonstrate a new hydrodissection technique in cases of high risk of iris prolapse to prevent the same. So this was a prospective interventional study where 41 eyes who had a risk of iris prolapse during cataract surgery were included in this study. Now all the patients were middle-aged men above the age of 50. All those patients who were either on tamsulosin or who had a shallow anterior chamber of less than 2.5 mm or whose dilated pupillary diameter was less than 6 mm were included. Females, complicated and traumatic cataracts were excluded from the study. A detailed ocular and medical history and ocular examination, including the anterior chamber depth, which was given by the optical biometry, and pupillary dilatation, which was seen on a slit lamp, was done to evaluate all the associated risk factors which have been associated with iris prolapse. After the detailed ocular examination was completed, the patient underwent routine cataract surgery, but with a modification in the hydrodissection technique. Now, all the surgeries were done by a single surgeon under local anesthesia. The hydrodissection cannula, as you can see, is passed through the center of the incision using the surgeon's non-dominant hand, and then it is positioned under the rhexis margin. Then the phaco is inserted through the primary ocular vein into the anterior chamber, occupying the main wound. Fluid is then injected in the usual manner, either to ensure a complete wave in one or two locations, and then the routine surgical steps were followed. So what were our results? So basically this is the age distribution chart, which shows 9 patients were in the age group between 61 to 65 and 8 were in the age group between 66 to 70. Now this study included 45 eyes of 25 patients. 16 patients were treated bilaterally, whereas 9 patients were treated unilaterally. and there were 22 eyes which had grade 2 cataract, 16 eyes which had grade 3 cataract, and 3 eyes which had grade 4 cataract. Now, amongst the risk factors, the alpha blocker tamsulosin accounted for 52%. Small pupillary diameter was seen in about 24% patients. 16% had shallow anterior chamber, and 8% accounted for short tunnel length intraoperatively. None of the 41 eyes had prolapse of iris from the main port or side port wounds during modified hydrodissection, and 2% or 1 eye did not show free nuclear rotation following modified hydrodissection. So basically here, as you can see in this image, when we do a routine hydrodissection through the main wound, there is increase in the velocity of the fluid in the main wound compared to the fluid velocity here in the anterior chamber. And due to this increased velocity here at the main wound, it results in decrease in the pressure at the main wound compared with the pressure in the anterior chamber. Also, because of this increased pressure in the anterior chamber, the root of the iris, it gets pushed to the main wound. Now, what happens in modified hydrodissection is the phaco probe with the sleeve is blocking the main port. So first of all, the pressure of at the root of the iris is less because some amount of fluid is also passively entering the phaco sleeve when doing hydro via side port. But even this slight amount of pressure which is created at the root of the iris, if the root of the iris has to go into some opening, there is no longer opening at the main wound, and so the only opening it can go to is the opening of the phaco probe. So the distance between the iris here, the root of the iris, and the tip of the phaco, which is centrally placed in the anterior chamber, is a greater distance to travel for the iris. And therefore, more distal location of the phaco tip from the incision provides more clearance between the iris root and the opening in the anterior chamber in modified hydrodissection technique. So the learning curve is not steep, given that cataract surgeons proficiently use their non-dominant hand during several steps of surgery. So what was known as iris prolapse is a potential complication of hydrodissection, and the risk is higher in patients who are on tamsulosin, shallow anterior chamber, and small pupil. What new does this study add is insertion of the phaco tip into the primary wound while performing modified hydrodissection prevents iris prolapse, and especially this is useful in cases with short corneal wounds with small pupils and in patients of IFIS. Thank you.
In the video that you demonstrated, what I felt was you didn't show hydrodissection. What you showed was the CCC.
It is hydrodissection from the non-dominant hand, left hand.
Yes, I saw that, but it felt as if the CCC only was
I think with the phaco tip, too much of phaco tip inside, your chances of touching the iris increases. Because you have to focus at both the hands and side. So it's not, what you have said is that it is not, there is a learning curve.
There is a learning curve, there is a learning curve, but given that we...
And what added advantage you will get, I don't know, but if you are having a long tunnel, I think that will seal and and your hydrodissection fluid which is going inside is adequate amount. I think that will take the things.
So basically, sir, wherein we have intraoperatively, if you are making a short corneal, if it happens, when you make a short corneal, especially in those cases, if you do this technique, it is helpful.
Okay.
No, basically...
In the hands of your surgeon, as Dr. Hussain said, that it's not that easy to keep the...
This was done by me only, and I'm not an experienced surgeon, obviously.
You did all this surgery?
Yes, yes, ma'am.
Yeah, only two things I want to say. One is, iris comes only because the fluid is directly under the iris.
Yeah.
So once you go in, after your exercise, you have a lot of OVD inside. So burp out OVD from the anterior chamber, make the eye very soft. And before you hydrodissect, use some fluid to irrigate the anterior chamber. So there is a track for the fluid to come out. Correct. And then you use your hydrodissection cannula, press down on the posterior lip of your main node. Press down. With that, you are keeping the iris also away from billowing. So that prevents actually. It doesn't matter. And second thing, if you still insist on hydrodissecting through the side port, always use a luer lock syringe. Always. Because a luer lock syringe. Because otherwise this will just come out and hit the iris or the ankle or the corner. Okay? Right. With that, thank you so much. It was a nice presentation.
Thank you. Next presentation.
Next is by Dr. Debasmita Maji. Yeah.
Yeah, good morning all. So after all these discussions regarding the adult cataract, this is on a lighter note. This is a community and pediatric cataract discussion. So I'm going to discuss regarding tribal Odisha eye disease study. This is regarding the childhood cataract surgery and the determinants of visual outcome in Odisha. So coming to what is tribal? Tribal means a collection of families who bear a common name, common culture, common language, common history, and reside in a common locality. Unfortunately or fortunately, Odisha has the third largest tribal community in India. 9.5 million pupils in Odisha, they are tribal. So we have selected the 9 tribal districts from Odisha, and we documented the all pediatric cataract surgeries done from these 9 tribal districts at our tertiary center at Bhubaneswar. We all know that pediatric cataract is the leading cause of global blindness and visual impairment among the children. And more than 50% of children, they had a delayed presentation to the hospital for cataract surgery. So the delay in presentation is due to the lack of awareness, low socioeconomic status, and the more barriers in a tribal community is the less accessibility to the main hospitals for the surgery, and they have their local beliefs. So we know that compared to adult cataract, the childhood cataract need early surgery and early visual rehabilitation to get a good visual outcome. Otherwise, it is a burden on the socio-economic status of the family and the community and also the country. There are very less studies from the tribal communities, particularly regarding the pediatric cataract in India. So our objective was to find out the demographic presentation, how these children are coming, what is the clinical features, how is the visual acuity, and how they are coming for the follow-up. So we focused only these points for the all tribal children who were operated. And we followed the definition of familial cataract, congenital cataract, and developmental cataract as established. However, for congenital cataract, many parents are not able to give the history whether it was developed before the age of 1 year. So we have included children with absorbed cataract with nystagmus or total cataracts also included as congenital cataract, where the parents are not able to give the proper history. So we included 352 children who were operated from 1st January 2015 to 31st December 2019 at our tertiary center at Bhubaneswar. They were all supported by the state government program, and all children ranging from 4 months of age group to 16 year of age group were operated. All the pre-operative evaluation methods were as per the established protocol for a pediatric cataract surgery. We have followed that pediatric lens aspiration along with primary posterior capsulotomy and intravitrectomy with or without PC-IOL, depending on the size of the horizontal corneal diameter, age-appropriate axial length, and in the anterior segments, whether any anterior segment dysgenesis present or not. And all the children were followed for the post-op day 1, 1 week, 6 weeks, and 3 months. Unfortunately, many children were lost to follow-up. We'll discuss further. Appropriate statistical tests were utilized. So we found that out of the 9 tribal districts, almost 8 districts have more than 50% of population were tribal. And 43% of the children, they presented after the age of 10 years, and more were male patients. 64% of the children had congenital cataract. Out of them, 11% had a family history of childhood cataract. The delayed presentation, more than 50% had bilateral cataract. The most common complaint was reduced visual acuity. The counting finger at less than 1 meter were the most common presentations. 26% children, we could not be able to put IOL due to small horizontal corneal diameter or contracted bag or unstable bag. Only 17% children completed the 3-month follow-up. When we compared the 6-week and 3-month post-operative outcome compared to congenital cataract, the developmental cataract children had a better outcome. Then we found out the contributing factors, that is age at presentation, unilateral cataract, worse visual acuity at the time of presentation, and presence of nystagmus, they were the most contributing factors for poor visual outcome at the end of 6 weeks. So when we compared this study with established studies from different rural areas of India, we found our children had a more delayed presentation and more children were lost to follow-up. So what were the causes for this poor outcome? Definitely delays presentation and unilateral presentation. Only 28% children had a BCVA of more than 20/60 at the end of 6 weeks, which was comparable to the studies from Central India, Western India, and the Western part of India and the South India. So there are two factors which affected this thing. The whole program was supported by RBSK, that is the National Children Health Program, where they have supported only up to the surgery part, but they have not supported the 1 week, 6 week, 3-month follow-up part. So these children, parents were not able to bring the children to the tertiary eye care center of their own. The second drawback was when we found out the distance, we found the 9 tribal districts from different parts of Odisha, different geographical location. We divided into 3 groups. We found 200 to 600 kilometer was the average distance. As the distance was increasing, slowly the number of children coming for 6 week and 3-month follow-up is reducing. So, sorry, can I continue? Yeah, okay. So our limitation was it was a retrospective study definitely, and we have less data about the socioeconomic status of the patient. But even that, this was the first kind of report for the tribal children from Odisha, and the take-home message can be replicated for other ecosystems of India also. So the two things that if we can strengthen the local district hospitals for the comprehensive eye care and post-operative care of these children at the local community, we will get a better result and the dropout rate will be less. So this study has given some idea that the state government can change a policy making to help this strengthen the follow-up facility of tribal children, provision of adequate healthcare facility closer to their residence, and frequent awareness programs by healthcare workers. Thank you.
It's a very unique study, I think very unique, and needs to be replicated across India because tribal children are desperately in need of, they are the neglected segment and need help.
Yes, sir. Thank you.
We'll just put no for that. No, no?
No.
The third
Last
person.
paper also we don't have to.
Pardon?
This last paper we don't have to give marks.
No?
Right?
Why?
Because this is from the best paper of the Odisha state.
I think Ferus.
Ferus will, but they have asked us to mark.
Yeah.
We have to mark the last paper. This
Yes,
one?
I think so. We have to mark the last paper also, na? Yes.
Okay.
Okay. Perfect. Yeah. You're going to correct?
Yeah, we are through, no?
Yeah, we are through. Sure. Thank you everyone for being such a patient audience. हाँ बाहर आके